there's a full classroom of high school students, ranging from freshmen all the way to a couple that are going into college. And they've been going from place to place throughout the department. They've been in the research labs, they've met with some of the clinical faculty, and it was just really impressive to me, the commitment and interest that these young people had, many of whom asked incredibly insightful questions, both from about symptoms, about the general system involved in taking care of people with mental health issues, about research. We brought them to a poster presentation. You can see my poster, which is in the lobby, but there was a bunch of research posters and they were eating it all up. So it's really incredibly gratifying to me to see that many people that interested at such an early age in mental health and in the things that we do. And each one of them had a different particular interest within the group, and so it was a really exciting thing. So Tracy and I got a chance to speak with them today and talk a lot about schizophrenia, to talk about psychosis and psychotic disorders, to talk about what it means for someone to be identified as at risk for a psychotic disorder, and what does that mean for them to have that experience, as well as to what does it mean for society to consider people at risk. Really, really interesting discussion with them. So I just thought I would just tell everybody about that, because I think that's one of those things that we don't always think about what the high school students are doing and thinking about, but this was just a really great group. And apparently it's gone so well so far that over the next few years, I think every summer there will be a dedicated high school immersion program. So be on the lookout if you know some interested high school students. So I am from this area. I grew up in Palo Alto. In fact, I grew up immersed in mental health, and then my mom was a psychiatric nurse in San Mateo County currently, but when I was born, I was actually born at Stanford Hospital. She was working at the inpatient unit at Stanford at the time. And so mental health has been something that I have paid attention to and been involved with since my earliest memories. And all along, I've spent a lot of time involved and associated with groups and with people with mental health disorders, people with psychosis, and with schizophrenia in particular. And I was fortunate enough, after graduating medical school, to come to Stanford for my residency, bringing things, what I thought at the time was actually completely full circle. Little did I know that I was going to finish residency, and after deciding, well, I'm sure I'm never leaving this area, I was going to get on a plane to New York City for a few years to do the Schizophrenia Research Fellowship and to begin my academic career at Columbia. So I was there, it was great, and but I was always had the calling to come back to California, and was fortunate enough to have the opportunity to come and start a program related to psychosis at Stanford. There had been some change in leadership, and so there was an opening to start a new program, which was, to me, incredibly exciting, because all along I've always wanted to be able to have a clinic and a clinical practice and an academic practice focused on psychosis and on schizophrenia. But what a daunting task to start from scratch, essentially. There had been research at Stanford in schizophrenia that had been done, and there had been a few people who saw a few clients, but by and large, this was an untapped area at Stanford. So, what to do? You know, I mean, I could set up shop, and I could, you know, tell the intake folks, bring me some people, and you know, we'll write prescriptions and send them out, and that'll be our clinic. Or we had the opportunity to really think critically about what would be in a well-designed clinic, especially an academic clinic. What kinds of services do we want to provide within the system that we already have, and how do we want to think about what we can build out as we envision the system that we want to have. And so part of what we're going to do tonight actually is solicit some of that feedback from you, because we're still very much in development mode. We may always be in development mode, but for right now, we just started this last September. So we're still just a few months into all of this, and really thinking about what are the next things that we need to build. But I want to tell you a little bit about what we have built and what we are doing, and then we'll open it up for discussion. So, at the Inspire Clinic, first of all, let's talk about the name. The name Inspire Clinic. We were trying to think about, well, what kind of a name do we want to have? And quite frankly, all of the clinics at Stanford that I'm aware of are named by their disorder. So that is a way of doing things, and it makes sense. There's clarity there. You know, maybe more or less where who you should, when you call up, you know kind of what to ask for, perhaps. But there was something that didn't sit right with me about that. First off, we are a clinic that works with people, and works with people who may have a disorder, may have an illness, may have a diagnosis, may have something like that, may have schizophrenia, may have a psychotic disorder. We also work with people for whom they don't have a diagnosis yet. They're not sure what's going on. No one's sure, actually, what's happening with them, and there's something that is distressing, but we don't have a word for it yet. And so it didn't sit right with us to name our clinic after an illness that maybe people don't actually even have. So we started to think critically about what would we call this clinic other than a psychosis clinic? And we thought, well, we provide integrated services. We are interested in partnering with other people within the hospital, within the department, within the university. Overall, we are interested in doing research. We're interested in providing education. And so we came up with a very long acronym that is INSPIRE. And then we realized that it was really a mouthful. So we took out all the words, and we kept INSPIRE. And it's easier, rolls off the tongue. INSPIRE Clinic. Plus, as I see it, the INSPIRE Clinic it really actually helps encapsulate the way that we want to think about how we're approaching care. It's not enough to think about, let's write a prescription and I'll see you in a month. Sure, I write plenty of prescriptions. That is important. That is part of what we do. But if that was the entirety of what we did, it'd be pretty boring for me, first of all, and I think I would be of less use than it could be otherwise. So, INSPIRE, we think about how we draw inspiration from the people that we work with. That we hope, as a group, that we are also able to provide a measure of inspiration. That we believe that we shouldn't set the bar too low for people. That the ceiling is plenty high, and that people should feel like their life trajectory can proceed the way they would like it to proceed. And so the word inspire, I think, is really helps encapsulate that. I did notice recently that El Camino Hospital just started the Aspire Clinic in the news. Anyway, so we are the Inspire Clinic. The Aspire Clinic actually sounds quite nice at El Camino, and so we have maybe a lot to learn from them as well. But we are the Inspire Clinic, so it's a little bit different. And I don't think either of us knew that the other was naming it. We spent a lot of time thinking about our partnerships in terms of our academic partnerships. So we worked a lot with the folks at UCSF and with their early psychosis program. And we also try to collaborate throughout the university as well, working in the departments of endocrinology and anthropology, among others. So that's how we named the Inspire Clinic. I'll take a minute to tell you a little bit about some of the services that we offer and the things that we do. So we do see people with who have a psychotic illness or who have been identified by one way or another as being potentially at risk. People come in, we do an extensive evaluation. Part of that includes meeting with Tracy for a psychosocial evaluation, and I'll let her talk a little bit about what that means and what we do there. We also work with Dr. Kate Hardy, who I think has not been here yet, maybe has been here. Should come at some point. Okay, Dr. Hardy is a really internationally known expert in cognitive behavioral therapy for psychosis. She goes all around the country, all around the world, really. Helpful that she's British, maybe that's why she goes around the world. But she goes all around the world teaching people how to do CBTP, as we call it. And we have recently started our first CBTP group therapy, and we provide some measure of individual therapy as well. And increasingly are now providing supervision for the trainees, both in the psychology practicum students and postdocs who work in our clinic, as well as with some of the medical psychiatry residents in CBTP and in general treatment psychopharmacology for psychotic disorders and schizophrenia. So we have, those are some of the clinical things that we do. We are an active research clinic. People who come to see me, we talk about that there's no quid pro quo per se, but there's a hope that as part of being an academic clinic, people would be open to potentially participating in research. We have some research studies going on, primarily with Dr. John Yoon at the VA. He does functional magnetic resonance imaging, which is where using the MRI scanner, they're able to see how activity in the brain what parts of the brain are active at certain times depending on different stimuli, and are able to compare that with people. Right now we're actually looking at people who have been identified as having schizophrenia and are either taking medication, have never taken medication, or have taken medication and are no longer taking medication, and trying to see what are some of the differences so we can understand a little bit more actually about how the medications maybe work and what are the things that are happening for better or for worse with taking medication. We also have a study that's just about to start, any day now actually, where we will be looking for people who are within 5 years of their first diagnosis, or the diagnosis of schizophrenia specifically. They actually will continue, if they work with me, they'll continue actually on their treatment as usual, but they will be compared with people in other clinics where they are will be assigned to take aripiprazole, the long-acting injectable form of aripiprazole. We want to see if there actually is a benefit that we would expect there would be, but has not really shown up in research very well for long-acting injectable medications given early in the course of illness to help with adherence, to help with just people maybe getting on the right track more easily, and maybe having fewer side effects is the hope. We'll see how it pans out. The study's just starting. We can talk about more about that if people have some questions as well. Maybe what I'll do right now then is turn the floor over to Tracy, talk a little bit about some of the psychosocial things you do, families.
Hello. Thank you for having me. Again, my name is Tracy Chesler, and I am a clinical social worker at Stanford. I've worked in psychiatry for a long time and just recently joined Dr. Ballon's clinic last November. So, as he said, we're an evolving clinic, and we are really wanting your feedback on what this looks like. A couple of things he didn't mention about our clinic, because we're part of the larger Stanford network, we have access to sleep specialists, to neuropsych testing, all on site right in our building. So when people come to us, they not only get our services, but they get access to a lot of other stuff as well, as we're kind of trying to figure out what is going on. Specifically, what I do is provide a lot of psychosocial support for not only the person that comes to us that's experiencing the symptoms, but we know that when this is happening, it doesn't just happen to the person, it happens to everybody that loves them. So a lot of what I do is not only work with the patient directly, but provide a lot of supportive services to everyone that comes to that appointment as well. And the kinds of things that I assess for are, basic needs type stuff. Can you drive? Do you have access to safe housing and food? And how can we help if not? Do you have a therapist? Is that something you're interested in? What other kind of community resources would be helpful for you? So we work really closely together to figure out what the larger picture is going to look like. Like Dr. Ballon said, we don't just want to be a place to get medication. We want to be a really holistic clinic that looks at the whole person. Can we help with, vocational training? Is there volunteer work that we can get you involved in? Because we don't want this illness to define the person. We want it to be a part of their picture, but not the thing that directs their future. Trying to think what else I can add. What's that? I do a lot of individual work with families. If patients don't want to come and see me, I work with parents as well, and siblings and children. And with, a lot of bandwidth is always an issue, and we're trying to get more of me. But we have also access to some really talented psychologists on our team, and hopefully some occupational therapists that are going to be joining our staff as well soon. All right.
So one of the things that is important actually is we really do put a large focus on families. And it's long since been known that regardless of any chronic illness, if a person in the family has a chronic illness of any kind, it affects the whole family. It may be more true in mental health, it may not be, I'm not sure, but I do know that there's no family that has a member in it that is identified as having a mental health disorder which doesn't impact in some way, shape, or form the rest of the family. Often extending even beyond those who are still living together, but in particular when people are living together. So because of that, we do as much as we can to bring families in. That may mean that family members sit in for appointments. It may mean that they sit in the waiting room. It means that, when permission is granted, family members are given access to be able to call. Because to me, it's also very important, not just is it helpful to get a second set of eyes on how things are going, but also I want to make sure that the stresses and the ups and downs that happen as part of being a family are something that we're taking into consideration, because it all feeds back on itself. And so that's one of the things that is really helpful about having both psychologists, but also by having a clinical social worker, is that we are able to then do a psychosocial evaluation where often a lot of family issues are identified. And in doing so, sometimes Tracy and I will split treatment a little bit, and I'll see one part of the family while she sees the other, or we will meet together as a team. However we can do it to be as collaborative as possible to try to make sure that we're not missing things, but also that we are thinking as broadly as possible about how to help with figuring out what will help someone be successful. And then that brings up, well, what does it mean for someone to be successful, right? Again, I think psychiatry historically has defined success as the doctor defines success. Well, is the person taking the medication? That's a success. Is the person staying out of the hospital? That's a success. And to me, that's limiting. So, I mean, there are plenty of hospital-wide benchmarks where I might get credit for those kinds of things, I suppose. But to me, thinking about success is much more important if it's coming from the people that I'm working with. And so that means trying to figure out, well, if somebody's in school, are we making sure that we are keeping a laser focus on graduation? Because once you get a diploma, they can't take it away from you. And making sure that people are getting what they need in order to make it to the end of school, or has a person recently lost a job or is struggling to maintain having a job. That's really important. And so we spend as much or more time in most of the sessions with people with me talking about what is it that's important to you, what is it, how can we help you get there, who are you doing things with, what things are you doing. We always talk about medication, if that's, because we have to make sure that we're not missing things, but we spend much more time thinking about what is happening for a person socially, because ultimately, and this gets to what we know about schizophrenia, the prognosis is best when people are active behaviorally. We can talk a lot about, if people like, about different symptom classifications, but when we think about the symptoms that are most reliable as far as predicting success, it's negative symptoms and cognitive symptoms. And those are the symptoms that are best impacted, not by medication specifically, but by being active in the community, by interacting with peers, interacting with people in the same room. It's well and good to interact with people online, but there's something that is very powerful and important about being in a room with somebody else. And so those are also often the hardest things to impact for people. But we spend a lot of time thinking about that and talking about that. So that's a lot of talking. What I'm really interested in is actually hearing from everybody and from the community at large about what are the sorts of things when you think of an academic clinic that you would expect or be interested in having, and we want to take some feedback, because again, we're still at the drawing board stage. We have a lot of ideas, things that we want to add that we haven't done yet are a focus on wellness, nutrition, exercise, and general physical wellness, because general physical wellness certainly feeds back in both directions with psychiatric and mental health, mental wellness. Lots of other things that we'd like to do, but I'm interested in hearing from the community, and or if there are questions that I can answer as well, or that Tracy can answer, we'd be happy to do that in addition. But I'd like to just sort of open the floor a little bit. Start right here.
Got a question of, in the last 10 years, apparently, there's been a lot of progress in the use of these medications. I got the impression that negative symptoms still have not been addressed adequately. Is there a reason for that, and is there anything we can do to make sure that that aspect of life is taken care of through the medication?
The negative symptoms. First of all, negative symptoms. Does everybody know what the term negative symptoms means? I used it a minute ago. So when we talk about schizophrenia specifically, symptoms are broken down into a variety of categories. The symptoms that historically they garner the most press, that are the subject typically in movies, in the media, and what most people would associate with schizophrenia are the positive symptoms. Positive not because they're good, particularly, but positive because they are sensations in addition to the normal sensory experience. Things like auditory hallucinations, delusions, such as paranoia or other persecutory feelings. Those are the things that people often associate with schizophrenia. It turns out those are the things that are easiest to fix with medication. Or the medications are all ultimately, that's the thing that medications work most closely with. We can talk about how well we've done with that as a second question perhaps. We've done fairly well, but not perfect. Negative symptoms are much more difficult for us to treat. The negative symptoms are things like, they sort of almost all start with A, because they all imply that there is a deficit of some sort of the normal experience, perhaps. So things like lack of motivation, inability to experience pleasure, things that in many ways resemble depression, but strangely enough, must be different than depression. They don't respond to the same medications that respond to depression. And one of the reasons we haven't figured out a medication yet for that is that we were lucky in how we got medications for positive symptoms. Many of them were ultimately serendipitous findings that ultimately one was able to then extrapolate and create many, many new medications around. And in essence, they're all versions of the same thing from the 1950s. So they may have various tweaks that have in some ways made things better, in other ways made things worse. But they're all variations on the theme, and they're all, to some extent, are reasonably effective. We haven't had that finding negative symptoms yet. There are a number of things that people are looking at for negative symptoms. Probably among the best studied interventions for negative symptoms is actually cognitive behavioral therapy. And so behavioral therapy, behavioral activation, working through the types of things that Dr. Hardy can explain far better than I can, that actually has shown some benefit in terms of negative symptoms. So that's important because I like medications. I mean, when they have a place and they are helpful, but they are not the be-all end-all. It's nice to know that one can change the brain, one can change experience, one can directly influence the outcome of somebody's life through something other than a chemical. And so that's where CBT is very helpful, in particular negative symptoms. One of the things that we are in the beginning investigation as well is some of the brain stimulation techniques. So brain stimulation most commonly is thought of, let's say, as ECT. That's the longest standing version of brain stimulation. Very effective with depression. Comes with a whole host of issues. not something we need to focus on for tonight particularly. What we're more interested in is actually types of brain stimulation that don't require having a seizure. So those are things like, and the acronyms come fast and furious, and the words get long, but transcranial through the skull magnetic stimulation, so basically using a magnetic coil, which can more directly focus a beam of electromagnetic fields on specific parts of the brain. They're learning how to target, actually, right now it only does the surface parts of the brain, the cortex. They're working on new techniques that actually will help go into the inner parts of the brain as well, where some of the other systems are. So that's one thing that I'm excited about. And we're working on trying to bring a research protocol to Stanford that will allow us to do some of that, at least in a research context. And then there's also what's called transcranial direct current stimulation, or TDCS, which is a variation on that also can be effective. TMS, the first one, requires somebody to come to the clinic every day, 5 days a week, for about 10-15 minutes at a time. TDCS has the potential, ultimately, to be more easily made so someone can actually do it from home. So there's a lot of, to me, there's a lot of interest in those kinds of techniques. Ultimately, the biggest paradox and one of the bigger failures of the field is that, in fact, what we know is the most important aspect of providing benefit for folks, focusing on negative and cognitive symptoms, is the area where we have the least ability to do that. So an active area of research, an important area of research, but one that I'm hoping that over the course of my career will make some headway on.
I was wondering if you're willing to meet with family members of an individual who is not willing to come to the clinic himself.
That's a good question. Yeah, I think the answer is that as willing as I might be, I'm not sure that I'm able to do that.
I might have more bandwidth for that because I build differently. It's more of kind of a logistical question, but there are also questions around HIPAA and privacy. So that's not an easily answerable question, but definitely something we can talk more about.
Another question, do you take Medi-Cal patients?
Rather, we do not.
Our inpatient does.
Inpatient does not, or outpatient is not contracted with Medi-Cal to do that. Now, if a person has Medicare and Medi-Cal, they can come to the clinic. But Stanford, for one reason or another, does not take straight Medi-Cal for the outpatient clinic.
Hi, I actually have a few thoughts. So your original question had to do with things the clinic could help provide. And the things that come to mind for me have to do with allowing the patient to be not feel a invisible chain, to have to live close to home and not be able to have dreams for moving around the country or do whatever they're, especially when they're young, wanting to do, because as a parent, that's the part that makes me cringe the most, having someone who has that bug for seeing the U.S. or whatever, and knowing that he should be able to do it, but he needs to be here for appointments. So, being able to telemedicine and the whole concept of continuity, because if he wants to go live someplace for a while, he shouldn't have to start over someplace. And it's just so frustrating, because continuity is so important, which leads into the question having to do with Medi-Cal. At least I don't understand if it's all over California or just Santa Clara County. My understanding, and correct me if I'm wrong, and if there could be some kind of petition or something started about this, that the way Medi-Cal in Santa Clara is you can't have dual insurance, which first of all you would think would be to Santa Clara County's benefit, because it would cost them less if you could take advantage of the dual insurance that they someone's willing to help the patient. And it allowing someone to be able to maybe be in a, not doing so well, getting better, trying to move forward with their life, but have, again, continuity if they slip backwards from whatever they're trying to do. And it's so frustrating. I happen to be involved with a clinic, and we're having this discussion too, and I'm trying to get, is there anything we could partner with to get a petition, whether it's Santa Clara County or all of California, just, point this out, this is stupid. So that's my input.
Sure. Well, I will say, I don't know, I'm sure many of you are familiar and maybe saw the recent article in Palo Alto Weekly about the complete lack of adolescent psychiatric inpatient beds in Santa Clara County, which is shameful.
I just wanted to add, I really empathize with you because the way that the Medi-Cal system is set up, you have to stay within your county. That's where you get your care. No one wants to pay for, no counties, the way that it's financially structured, no county wants to pay for another patient's care. That's how they look at it. And you're right, a patient with Medi-Cal cannot have a secondary insurance. That's not a Santa Clara County thing. That is a statewide policy.
So fragmentation is a huge problem. It's a huge problem in our healthcare system. It's a problem on a local level, because all politics are local, but it's a problem on a national level as well. And so telemedicine is one thing that is on the horizon. And at Stanford, we are hopefully, getting that off the ground, very slowly rolling that out. We have our first telemedicine dedicated room where we're able to see people provide secure video link. It's a technology that, as with all technologies, there are pros and cons, and there are potential hurdles and things that need to be worked out as we go along. But I agree that, so I see a lot of college students, right? If you think about, again, the age of onset for schizophrenia is late teens, early 20s, and then early to mid 20s in women. So to the extent that I'm able to focus on people who are in that just before period, considered at risk or early in their illness, a lot of people who come to see me are in college or about to go to college. And so what do? If they come and see me while they're in school, and they go home for a summer that's further away, or the kind of conundrum of the day these days that many colleges face is what to do with somebody who has had either a first episode or had a psychiatric hospitalization of any kind. Do they allow them to stay in school, or do they send them home? And colleges do things in different ways. Stanford tends to send people home for at least the end of the quarter to recuperate, which has lots of pros and cons. But again, that person is now removed from their community, and so they're able to recover at home, but they don't have their community. They may not have their provider, their healthcare provider. So what can we do as a system to address that? Telemedicine is definitely a start, and hopefully we'll have that happening a bit more readily available at Stanford soon. But I know that it is definitely something that is still in the works, but getting closer all the time. I'll let you pick.
I was very pleased to hear that you push to help college students that you see. You help to push them to complete the degree. It was very helpful for me when I had episodic illness, so particularly for episodic illness. I'm very pleased to hear that from you. Thank you.
Thank you.
I didn't actually get a handout, and I missed the beginning of your lecture, so I hope I'm not redundant here. My understanding is that you have a special interest in adolescent diagnosis, correct?
Well, I'm not a child psychiatrist. I do work with someone who is an adolescent psychiatrist. I don't see people as young as age 16 or 17.
So I had onset at adolescence, and received formal diagnoses reaching into my late 20s. And it's really come to the fore that it's more of a post-traumatic stress that had its inception in childhood and was reawakened through trauma that happened after college. And so I have symptoms as somebody who had early onset in adolescence, but I'm 35 this month. So there's a complex dynamic happening, and I'm trying to work with alternative modalities, and I'm finding a lot of success. And so I appreciate you being here, and I just want to celebrate that Stanford's doing this because I've worked with Jennifer Culver, and you mentioned CBT, and I know Dr. Reiser, who teaches at Palo Alto, in South Sophia University, I believe, and I worked with him briefly, and there was no efficacy there, and so I moved on, and I found DBT to be very effectual for me personally, and then I moved on, and I worked with Spirit Rock Meditation Center in Woodacre, California, which I just have to give a shout out to, and then I wanted to connect with you afterwards, and I want to encourage people in their comments, if there's anything like a petition or something that you'd like to see happen in the world today to make a positive change for the better. This is a good forum to do that, and just identify yourself, and we can meet up afterwards. There's coffee and flyers and things in the lobby. So I'm interested in that, what you said specifically, and I hired my daughter's health insurance, so I can talk to you about that. But yeah, so my question I guess is, how do we address these issues for the greater population? Because this is rarefied air right here. And it's rarefied air that I have Medi-Cal and Medicare, which is unusual. And I could see you, and I would love to work with you more. So I'm not going to ask any more personal questions, but my issues, I have friends. I went to Fremont Hospital, and there's just the continuity of care isn't there. And the continuity of care from one county to the next, from Kaiser to their contracting agencies. And there are people who are cycling. I know a gentleman, I won't use his name, but he's been hospitalized 7 times in the last 2 years. And he was just hospitalized for an 8th time. And he has OCD, and he has some issues that come with being in an awakening space with his sexuality and being a young man, and it's very complex. But he came out of the hospital, and there was no continuity of care. And he's trying to put his life together, so he's going to the gym, and he's meeting guys, and then he ended up with an OCD event, and he didn't tell me, so I couldn't help him. And now he's telling me he wants to get a job and he wants to go to school. And I said, whoa. And then he said, so this is just one example, and I don't want you to respond to his case specifically, but what can we do, and anybody out here who has an idea, I want mass care. I like, boom, we're in the internet age. Right. There's the jungle. They disseminated the jungle right here in San Jose. Yeah. We have the largest homeless population, and I used to volunteer for Envision before they shut down the women's shelter, and there isn't care. So people would call me and they'd say, I'm a social worker in a hospital, a woman just gave birth, her family won't take her in. Right. What do I do? And I said, I'm sorry, there's no rooms. She could wait for a month, and then she'd have 90 days in our shelter, and that's it. She has a newborn infant. And so what do we do in a compassionate environment? You're compassionate people. Right. Your treatment plan is very holistic, which is beautiful, and you have a limited framework. But we are a larger community here, and I would like to see more people treated and helped by the community at large. And I know there's NAMI, has probably meetings, and DVSA has meetings, and there's out of East Bay there's something for people who don't want to take medication. Right. So what do we do to help the larger community with these modalities that you've been discussing?
So that's a great compassion question. I think so, and I appreciate your candor there. I think that there's a number of things that we think about as we think about how do we address the community, how do we get the community on our side. Obviously, NAMI has done tremendous work over the years around stigma, and how can we help to break down the stigma that the community feels often feels unfairly towards people with mental health issues, and how can we break down the stigma that is internalized, that many people feel about themselves, and feel that they have certain limitations that maybe they don't actually have. And so I think that it's important for us to work holistically, to reach out into the community so that people get a positive impression about what it is that we do, that demystifies what we do. That's why I was so excited about the high school students that came to spend a whole week with us, because these students are going to go out and do all kinds of things, and they're never going to forget the various things that they saw in the department this week. But it is a very tough question. The fragmentation issue is one that has pernicious fingers throughout everything, right? At every transition point, there is an opportunity for a person to either have a successful transition from one thing to another, or to fall through the cracks. And our system is right now set up in a way that makes falling through cracks kind of the default. That in order to protect privacy, often that comes at the cost of making communication a little bit more difficult between clinicians. It's a shame, but that sometimes does happen. But also, our systems are set up, private systems, public systems, they're set up in a way that makes it can make it difficult to make sure that all those transitions happen. Now, what do we do at Stanford? If somebody's coming from the inpatient unit at Stanford and is going to come to see me in the clinic, then we make sure that we do as best as we can to make sure that transition is as seamless as possible. And certainly do our best for the patients that we work with. We do end up in the hospital to make sure that when they are discharged, that we keep track of what's going on. But the system is large and is fragmented, and it does pose a lot of problems. As people come on and off of insurances and all these things, there's a lot of roadblocks, And so part of what we need to do as a community at large is to really think about how we can really create our own safety net. NAMI is a hub and a home that for a lot of families is able to at least provide some of that service, and that's one of the reasons why I think it's so valuable.
Hello. My son is now getting treatment, but there was a long period of years where he was psychotic and not getting treatment. And he was delusional, but lacked insight into his own disorder. Do you think that our county would benefit from having mandatory outpatient assisted treatment required by Laura's law?
So, okay, well, so that's, there's a lot to that. I struggle with where to draw the boundaries between autonomy and freedom and the right to maintain have symptoms and be ill in the face of not always understanding and being able to recognize from an outsider's perspective what that's doing for a person. There are definitely times as a clinician where I've looked at a person and said, my goodness, I wish I could just force them to do what I think is right. And I often check myself when I'm having that impulse, because that's coming from me, and it's not necessarily coming from them. Now, where the outpatient treatment laws have come into play is, of course, when there has been, when there are violent risks and things like that, and I think that there's room for that. I think it's always been a difficult thing to fully administer and oversee. And I've never personally been part of having patients who are on mandated assisted outpatient treatment. And in the times where I've been involved in inpatient care, where it's been treatment over objection, it's a difficult challenge. It's a tough feeling to take on that paternalistic notion, knowing that I believe in my treatments and that my treatments would help somebody, but that they don't believe in it, and that it's a difficult struggle, a difficult ethical struggle.
I would also like to add that one of the tricky things about that is that there's such a huge disparity in the quality of care, and some programs are much better than others, and so to make something mandatory, I professionally have been in the position of requiring, or the system at large is requiring a patient to participate in a program that I don't necessarily think is that good, and I wonder how effective it's going to be for that person in the long run. So I think, again, it's one of the primary questions is also quality. If we have high quality outpatient treatment programs that are very individualized, I think that we can all feel better about making it mandatory, but that's, I don't think, where we are yet.
The counties that have adopted Laura's law have a very high percentage of success in getting patients to take medication. And it was only through taking the antipsychotic medication that my son gained insight again and became cooperative and was happy to have the treatment that he's getting. But until he got the medication, he was very, very psychotic, to the point that police told me it was too dangerous for me to be around. And I was told repeatedly by NAMI and others to let him become homeless again. Let him go hungry so he could meet that qualification to get hospitalized. That is immoral. That is insane. That is a health careless system, in my view. We have to change.
I will say, in my experience, having, again, seen people who take medication against their will and seeing people who don't, there are many folks who have a very similar experience where once symptoms are able to calm down a bit and they're able to look at things in a different perspective that because of the nature of the illness, they can't have in that moment. And it's a big struggle. And it's a big struggle to get people to that point where they don't want to get there. And it's gratifying when we do get to the other side and people say, gosh, I just really wasn't in a position to make those decisions before. I'm glad that it went this way. There are other times where it goes the opposite. And it's been different in inpatient versus outpatient. But again, I agree that it's hard to argue with numbers and with the data. So, but I don't know where Santa Clara's administration lies on that at this point. I know that it's been poorly adopted throughout California, so it's always been a big question.
Well, kind of following up on that, our son is going through psychosis without treatment because he feels that the pharmaceuticals are the evil ones. And he feels that pot is the answer. And so we're in a place where we feel that that exasperates the psychosis, and he's feeling like there's no way he's going to take pharmaceuticals. So it's a very hard place to be, and I agree. We've been told, just let him become homeless. Which, if for anyone going in life, they need sleep and diet, and your basics in life are basic to health. So if you're being told, oh, just let your child become homeless, where they're not going to get sleep, they're not going to have diet, they're going to be isolated, they're going to have no one to turn to, they're going to have no one fighting for them. So it's such a hard place to be, where I feel the treatment of coming to the home would be tremendous, and I agree. We have so far to go. We're all here in agreement, I'm sure. My mom was diagnosed with bipolar 50 years ago, and I feel like in that time frame, there's been, I feel like, very little progress from what she went through and what's available today. And it is very sad to see that we have so far to go. But I do hope they can do more home care available for those who are stuck in a place where they have loved ones who are refusing treatment, and knowing that that is the path for their wellness and wholeness.
Well, I think that's a great point. I think when we look at the most successful public health, mental health interventions, they share a commonality, which is they find people where they are and provide treatment where that person is. And this goes to the telemedicine comments as well. I sit in my office and people come to me, and that's really convenient for me, because that's where I am, and I can see people one after the next, and that works for a lot of people. I mean, that's a reasonable solution. That's, I take my kid to the pediatrician, and they don't come to me, and that's fine. But mental health is much more complex, and a thorough mental health system really does. Now, there are assertive community treatment models, and there are varying models. Those tend to be affiliated more with county systems than with the private systems, but not exclusively. Many of them are quite effective in helping to find people. We've been exploring what would it take, how could we, given various logistical billing and insurance and blah, blah, blah limits that we have, how could we see people at a cafe if we needed to? We had the experience recently of somebody who was interested in coming to treatment, came with their parents, got as far as the parking lot, took one look at our beautiful building and said, no way, I'm not going in there. And we struggle because right now we don't have the ability to see that person even across the street. They have to physically come and check in. So we're trying to think about how we think more broadly into how can we reach people where they are. Now, the marijuana question is one that I'm sure you can predict my answer. Just to say that there is no marijuana that is helpful for psychosis. There are marijuana strains out there that are marketed as helpful for various psychiatric comorbidities. Yet to see any data that supports that. Marijuana is obviously becoming a drug that is increasingly available, and by and large, it's probably, neither here nor there. But when it comes to specifically within mental health, there unfortunately really is very little place, especially within the folks that I work with, for chronic marijuana use. Now, I can't get everyone to stop, but it's certainly something we talk about. There are data that suggest that marijuana can be linked to that changing from that at-risk state to converting to psychosis. There is data certainly to support that that marijuana can impact paranoia and hallucinations for the worse, especially as one is coming up and feeling high and then coming down and feeling more anxious. So I try to work with people where they are, and there are folks who are not willing to stop, and we try to talk about it and try to figure out when they're willing to think about stopping, because unfortunately they don't, my telling them isn't necessarily enough, but they certainly know where I stand on the issue, and then we work and wait until see when people are more ready to change on their own schedule. But certainly there's no documented benefit for marijuana in psychosis. We have about 5 minutes left, I guess.
Okay. Well, two things. Just to address your issue, my son refused treatment for several years, and we finally had to make him homeless and said, we'll pay for a place for you to stay if you could go to the doctor. And it took 3 months of being homeless. He could park at the parking lot at Kaiser, maybe go inside the building, but he wouldn't go into. But anyway, my question I really wanted to know, I think you've partially answered it. You said you don't take Medi-Cal, but you do take it with Medicare.
Correct.
And what health insurance do you take?
Well, that's a complex question that thankfully
Because
outside
you
of
don't
my
take
pay.
Kaiser, I guess.
No, Kaiser only takes Kaiser.
Yeah.
Let me clarify, we don't take Medi-Cal at all. We only take Medicare. So we don't bill Medi-Cal if you have Medicare. We just
We
take
take Medicare.
Well, I'm not sure what you have if you're on SSDI or SSI, because you have both of them.
Often you have both. So I will say this, the insurance question is thankfully one that I try my best not to think about. I mean, I try to think about it in the grand scheme of things. I am definitely, it's a challenge not to take Medi-Cal, but that is the challenge that I'm dealt with right now. But when a person calls, and the process for coming to the Inspire Clinic, maybe as we wind down, for those who are interested, you call the general standard intake number. They will talk with you about your case or about your loved one's case. It's best when the consumer makes the phone call, and it's done in conjunction with a family member or a reporter that can help to either fill in gaps or just provide again the second level of information. And in speaking with the intake worker, they will also then vet the various insurances, because I'll tell you that it isn't even enough for me to say, well, we take Blue Shield and we don't take Cigna, because we take some Blue Shield and we take some Cigna and we don't take others, and I can't keep track of it. It's maddening. But the people who do keep track of it are very friendly on the phone. They'll be happy to take the call. And part of what they will do also is they will think about the case. There's a lot of folks at Stanford who treat a wide range of psychiatric illness, and sometimes the Inspire Clinic is the right fit, and sometimes there are other clinics or other providers that might be a better fit, and so they'll steer you in the right direction. We just want everyone to find the best that we can do.
Do you have a phone number for that?
The phone number for the Stanford intake number is 650-498-9111.
Thank you.
Mm-hmm.
Do we have time for
Maybe one last one?
one more question?
I'll let you take it. I'm happy to stick around for a few minutes. I can't stay too late tonight, unfortunately, but I can stay for a few minutes to answer a couple of questions.
Listening to these ladies here and you speaking, I mean, we just, it's kind of scary, it's my first time here, but it's like reliving what's going on. After all this is said, is there any hope where instead of the hospital saying, well, he doesn't put your name on the list, you can't do nothing about it, we're going to give him money for a taxi, and wherever he wants to go, he can go and be dropped off. That's very inhumane for someone who's not there with his mind. And I feel it should start with the judges. There should be, because the HIPAA crap, I'm sorry for what I'm saying, but it's when someone needs help mentally, HIPAA is not helping them. Is there some hope where the judges will come in and decide for the good of that person to change from what's going on now to a better situation?
You know, I know that there was recently some kind of changes to that law, and I know at Stanford inpatient, I can't speak to other hospitals, but a couple things to your question. At Stanford, we practice slightly different. If somebody is indeed a danger to themselves, a danger to others, or greatly disabled, and they're in that very acute phase, and we need primary information about their history, their demographic, where they live, who their support people are, there are some workarounds around that initial HIPAA privacy communication law. Once you're out of that acute phase, it becomes more difficult to break confidentiality. But if somebody's safety is at risk or somebody else's safety at risk, then we can work around it. And also, I know at Stanford inpatient, we have a pretty strict policy around discharge planning. We can't discharge somebody without a treatment plan in place. That's not to say that a person will always go. You know, there, unfortunately, we can't physically sit next to them and make sure that they get to the facility or the program that they're referred to. But we would never discharge somebody without a clear treatment plan in place.
So we want to thank you. This was really interesting, and your clinic sounds wonderful. One suggestion that I'd like to make is to consider having peer specialists and family advocates as part of your clinics who are working in recovery and wellness, because we believe, and we see it every day, that they can be a catalyst to help people accept recovery. Okay. So thank you so much.
Thank you. Yeah, Brandon's our good buddy. Break your stigma. Mr. Stanford, man. Break your stigma. I love it. I follow him on Instagram. Oh, great. Good. Nice to meet you.
Say hi. I'm here. Hey, hi, sweetie. How are you? Oh, okay. I'm here. I just like to did they have a man out?